speaker for this afternoon. Just a disclaimer, she is not a foreigner. She is a full-blooded Filipino citizen. As you can see, her CV will be shown in the screen, so let's just give you the highlights. She is a leader of Diagnostics Network. This is her present involvement of the, I hope I will pronounce this right, Médecins Sans Frontières. In English, Doctors Without Barriers, which is based in Geneva, Switzerland, and she works as an infectious disease specialist. Her favorite specialty in infectious diseases is HIV. She's also involved in various research works both here and internationally. When I was talking with the chair, Dr. Alora, if she knew the speaker, she said she does not. I also didn't. And how are we going to introduce her? I can't see her yet. And Dr. Alora said, ask her why she accepted the invitation to be the speaker for the first plenary. So I did, like a good student. I followed my mentor and I asked our speaker, why did you accept the invitation to be the speaker? And her answer was, because I can't refuse the one who issued the invitation, my former classmate, Dr. Mario Panaligan. So ladies and gentlemen, please help me welcome our first plenary speaker, Dr. Arlene Christine Chua.
Thank you for the kind introduction. I'd like to thank the Philippine Society of Microbiology and Infectious Disease for the invitation to speak today. Of course, with special thanks to Dr. Mario Panaligan, so blame him. So it's really an honor for me to be here today, and I'm really quite happy compared to other infectious disease conference internationally. There's a feeling of lightheartedness and banter that's so Filipino that I miss so much. So thank you. All right, so the title given to me is, for this talk, is the expanding role of the ID physician in the control and prevention of global communicable diseases, challenges and opportunities. So the title itself is challenging, but I will do my best. So I will share my perspective on the infectious disease of global importance and illustrate the challenges and opportunities with 3 examples and the expectations and roles that as ID physician we can do to address these challenges. As an infectious disease clinician, our role is to diagnose, to care and treat. Medicine is a noble profession, but it is not always perfect. We know it can be good, but we also know early on that it is not always fair. We all have these experiences that make us feel helpless because our patient cannot afford and access the diagnostic test or treatment or vaccine that they need. But because of our unique position to see firsthand as a clinician the challenges that face our patients, we also become advocates on access to treatment to our patients. So I'll go through the challenges and opportunities. Okay. Sorry. I'll describe the breadth and type of infectious diseases that face us today, And like I said, I'll go through with a few examples: antibiotic resistance, tuberculosis, and MERS-CoV. So the last report on the global burden of diseases show that while non-communicable diseases now account for more than 1/2 of the global burden of disease, in many low and middle income countries, especially in Africa and in children, infectious diseases remain to be a big problem. As shown in this map, drawn based on the infectious and parasitic deaths worldwide. Many illnesses and conditions are caused by infectious diseases, and many chronic diseases continue to also be reclassified as infectious, such as cervical cancer, Kaposi sarcoma, and H. pylori, among others. Aside from that, a category called emerging or newly recognized and re-emerging infectious diseases, previously recognized, has been added into the scene. Several reasons account for the emergence of diseases, including microbial adaptation to new hosts, population immunity pressures, animal migration and movement, such as West Nile virus in France, H5N1, avian influenza, microbial escape from antibiotic pressure, such as drug-resistant TB and antibiotic resistance, microbial, travel, international trade and commerce, poverty and social inequality, war and famine, breakdown of public health measures, changing ecosystems, climate and weather, and lack of political will. I'd like to illustrate the challenges further with the 3 examples. I'll start with antibiotic resistance. So antibiotic resistance, be it in the hospital, the community, or on the farm, our overuse, misuse, and abuse of antibiotics is rapidly causing a regression to what many are stating as a warning to a pre-antibiotic era. What does that mean? That the wider implications is beyond threatening our ability to cure common infectious disease. It is also threatening to undermine major medical advances such as surgeries, treatment of cancer patients, and care of preterm babies, where we could lose confidence in our prophylactic antibiotics, for example. And we know that antibiotics are a cornerstone of medicine. In 2017, WHO published its first ever list of antibiotic resistance priority pathogens. This is a catalog of 12 families of bacteria that pose the greatest threat to human health. The list highlights in particular the threat of gram-negative bacteria that are resistant to multiple antibiotics. These bacteria have built-in abilities to find new ways to resist treatment and can pass along genetic material that allows other bacteria to become drug-resistant as well. The list is also meant to guide and promote research and development for new antibiotics for these infections. It's divided into 3 categories. You have the most critical group, which includes multi-drug resistant that pose particular threat in hospitals, nursing homes, and among patients whose care requires devices such as ventilators and blood catheters. So these are your Acinetobacter, Pseudomonas, and various Enterobacteriaceae. They can cause severe and deadly infection, bloodstream infections, and pneumonia. They have become resistant to a large number of antibiotics, including carbapenems and 3rd-generation cephalosporin. And the 2nd and 3rd tiers in the list, the high and medium priority categories, contain other increasingly drug-resistant bacteria that cause common diseases such as gonorrhea and salmonella. The problem is that there has been no truly new antibiotics that have been discovered and that has reached the commercial market since the 1980s. What is a novel drug? So this is either a new core chemical structure, a drug, or a bacterial structure, a target, that has not been previously used, or there is an absence of cross-resistance to any developed antibiotics. Here we refer not only to antibiotics for human use, but also for veterinary and agricultural use, because as we know, the use of antibiotics goes beyond human health, and the problem, as you know, is well interconnected. In September 2008, what's the latest in the pipeline of new drugs? The Pew Charitable Trust actually did a reassessment on where we are. So in the pipeline, they found 42 antibiotics in clinical development. 15 were in phase 1 clinical trial, 12 in phase 2, 11 were in phase 3, and 4 have been submitted for regulatory approval. You compare that to the pipeline and the WHO priority list, and only one new antibiotic who is in phase 3 is considered novel by the criteria applied by Pew Trust. It is a beta-lactamase inhibitor, but this is not really a new class of antibiotics. So there is still a lot of work to be done. Why is the pipeline dry? So in brief, lack of sufficient profits from antibiotic has caused many companies to abandon antibiotic discovery programs. It's not because that the risk on research and development are too high. It is that the rewards are too low. New antibiotics are being introduced, but their sales are really a small fraction of sales compared to other drugs in other diseases. So this for-profit approach to fund biomedical R&D is flawed, especially for antibiotic development. As you know, although resistance is a big problem, just a minute, let me just go back to that slide. Yeah. Although antibiotic resistance is a big problem, most infections are treatable by well-established low-cost antibiotics. This is true even of infections caused by resistant bacteria. Most are resistant to only 1 or 2. Very few are resistant to 3 or more. And really, right now, a small proportion, for now at least, a small proportion are resistant to all. The result is then limited demand and weak pricing power for new antibiotics. New antibiotics that treat more resistant infections are often also reserved by doctors, and rightly so, for fear that excessive use will lead to the development of resistance. So the pipeline is dry because the current business model is flawed. The other problem facing antibiotic resistance is the diagnostic gaps. So the current diagnostic test that we rely on is based on methods and principles that are probably more than 75 years old. Its ability to culture, it's a culture that identifies bacterial species and based on diffusion or dilution methods to determine susceptibility. The limitations, as you know, culture method is slow. Identification susceptibility will take at least 48 hours or more, and maybe even longer for some slow-growing organisms. Of course, there are automated blood culture systems that makes it a bit faster, but in low and middle income countries, the availability of automated blood culture systems is expensive and out of reach. So in general, countries in low and middle income countries are still relying on manual method of identification. And not only, and the problem there is the availability of reagents. Some may also just have short shelf life. Access to reagents may not be sustainable. There's also a lack of trained technicians. As a result, there is a lack of bacteriology capacity in many settings, and gaps in surveillance is obvious, such as shown in this map by GLASS. Launched in October 2015, GLASS, or Global Antimicrobial Resistance Surveillance System, was developed to support the Global Action Plan on Antimicrobial Resistance. WHO with this GLASS aims to support the surveillance and research in order to strengthen the evidence base on antimicrobial resistance and help inform decision-making and drive national, regional, and global actions. GLASS promotes and supports this standardized approach to the collection, analysis, and sharing of AMR data at the global level by encouraging and facilitating the establishment of national AMR surveillance that are capable of monitoring AMR trends and producing reliable, comparable data. However, how can countries meet this goal without access to bacteriology? We conducted this study. It's an inventory of AMR surveillance at supranational antimicrobial networks involving low and middle countries since 2000. And what we found that the biggest challenge was achieving a high coverage across low-middle income countries and complying with frequency of reporting. Obtaining high-quality representative surveillance data in low and middle income countries is very challenging because AMR surveillance requires lab infrastructure and training that is not widely available in low and middle income countries. I want to touch a bit on sepsis, a swan infectious disease syndrome where we need to give the right antibiotics at the right time, and the diagnostic challenges. Sepsis is among the most frequent acute medical conditions worldwide and result in approximately 8 million premature deaths each year, most of which occur in low and middle income countries. Delayed or inadequately treated infection accounts for a relevant number of patients with sepsis in low middle income country hospital. This implies that early and appropriate management of patients with acute infection could reduce the incidence of sepsis, associated morbidity, and mortality. Another important consideration is the presence of antimicrobial resistance, and in some countries, in low and middle income countries, this is widespread, rendering commonly available antibiotics ineffective. Therefore, it's even more imperative to have the proper diagnostic tools. However, this is not met with currently available tests. In this review on emerging technologies, the authors kind of put like what would be the ideal sepsis diagnostic test. So it's not a no-brainer. We need something that can rapidly detect the pathogen in less than 3 hours. It should have broad-based detection abilities. It can detect bacteria, viruses, and fungi. It should have minimal invasion, utilizing clinical samples with low specimen volumes. It should provide high sensitivity and specificity so we can act on the results right away. Detection of drug resistance, and integration into the clinical workflow so that the process should be easy to use and require minimal technical expertise to process samples and interpret test results. And for the greatest impact, this technology must be available in non-centralized, low-resource settings. So in that paper, they did find that there are some technologies out there. It's probably hard to see, but I summarized. But it still shows that there's some degree of sample prep and handling that's needed that might not be easy to implement in low-middle-income country setting. It does identify the pathogen, but not necessarily the antibiotic susceptibility testing. So it begs the question whether these new technologies would be feasible and cost-effective and available in low and middle income countries. So in summary, for antibiotic resistance, we have a lot of diagnostic and treatment challenges. My second example is tuberculosis. It is the #1 infectious disease killer and among the top 10 causes of mortality worldwide. The TB epidemic is worsened by the rise of drug-resistant TB. Millions of people continue to fall sick with TB each year. In 2017, TB caused an estimated 1.6 million deaths. 10 million people fell ill with TB, and only 1 in 4 people who were diagnosed with multi-drug resistant TB were actually put on treatment. This year, WHO issued new changes for MDR-TB. Treatment guidelines and treatment options are increasingly more and more individualized. That drug resistance must first be excluded before starting patients on treatment. So diagnosing TB quickly and accurately, it's an imperative first step. In 2010, you probably know of the expert MTB RIF test by Cepheid. This was seen as a big advance on public health. It can diagnose TB and detect resistance to rifampicin in less than 2 hours. This rapid turnaround time makes it possible to start TB treatment right away. WHO also endorsed this expert MTB RIF and issued a policy statement recommending it as the initial test for presumptive MDR-TB or HIV-associated TB, and that indication was expanded to include children. However, access to this test is still a problem. In this survey, reported by MSF, and it showed that in the 29 countries surveyed, 52% which had adopted the policy of expert for all, only 47% of them have widely implemented the test. Of all countries that provide initial testing with expert MTB-RIF to high-risk groups, meaning people with HIV and people at risk for drug-resistant TB, only 54% have implemented it. For people with rifampicin-resistant TB, additional drug susceptibility testing should also be made available so that they can be treated with medicines most likely to be effective. So this universal drug susceptibility testing, or universal DST, must also be scaled up. And 62% of the surveyed countries recommended it, and among those who recommended it, only 50% actually implemented it. So with very low proportion of diagnostic coverage for TB of countries, the diagnostic gap for TB remains massive. This deadly gap must be closed so that countries can reduce TB illness and death. Most of the currently available TB diagnostics are also ill-adapted to resource-limited setting or specific patients' needs, or maybe priced out of reach. Many countries still rely on sputum smear microscopy, and although, like I showed, there have been some progress on and because the TB diagnostic landscape is changing, there are still many unmet needs. WHO put together this document focusing on the high priority diagnostic tests that's needed to address the gaps. My third example is MERS-CoV. It's an emerging virus associated with severe respiratory illness. First detected in 2012 in Saudi Arabia. It's a zoonotic virus, and dromedary camels are the reservoir host and the source of zoonotic transmission to humans. The camels themselves, they can only be mildly symptomatic, but they do present a significant reservoir risk for spillover events. So MERS RNA has been detected in the camels in a number of countries, including Egypt, Oman, Qatar, and Saudi Arabia, with evidence suggesting that MERS-CoV is also widespread in the Middle East, Africa, and South Asia. Individuals with close and frequent contact with these camels are at higher risk for developing the infection than the general population. The clinical spectrum for MERS ranges from no symptoms to mild symptoms to severe disease, including pneumonia, ARDS, and death. And risk factors for severe disease include a weakened immune system, older age, comorbidity such as diabetes, cancer, renal disease, and chronic lung disease. As of October 2018, WHO has been notified of around 2,000 lab-confirmed cases of MERS-CoV from 27 countries, including 800 deaths. Human-to-human transmission spreads through close and unprotected human contact, and more than half of reported MERS cases have occurred through nosocomial transmission. There are currently no prophylactic or therapeutic interventions of proven efficacy for any coronavirus infections. Without a specific therapy for MERS, treatment is supportive. There are some effective MERS treatment are still in the early stages of research and evaluation. The WHO R&D Blueprint has called for 3 types of vaccine. One is actually an animal vaccine. It's a camel vaccine to prevent zoonotic transmission. And 2 human vaccines for long-term protection of people who are at risk and reactive use in outbreak settings. The status of these vaccines, so the MERS-CoV vaccines, they're also, again, in the early stages of development, with 1 candidate vaccine in phase 1 clinical trials. So what do these 3 examples have in common in terms of the countermeasures that we need to address this, whether it's diagnostic, treatment, or vaccines? So either the countermeasure is not available, or if it's available, it's not appropriate or adapted to low middle income countries, or if it is indeed available and adapted, it's not accessible or affordable. The opportunities. So I put it like two ways how we can have my presentation here. It's important to articulate the needs based on our setting and how to get there, and some developments on how we could improve access. For some infectious disease, the non-availability of a product, it's not because it is not technically feasible. Ebola is a good example. In the last big outbreak in West Africa, before that outbreak, diagnosis of Ebola was relying on BSL-3 facilities, lab-based PCR testing, but then it was feasible to develop smaller, automated, all-integrated molecular tests that can be used in a decentralized setting and nearer the patient who needed it the most. So what is needed? First and foremost, we need to clearly articulate what we need. What are the key considerations and specifications that researchers and developers need to know to design and develop the tools needed in low-middle income countries? This is usually expressed in a target product profile. So it's a document that expresses the key features of a drug, vaccine, or diagnostic test. For the example shown above, the specific features are based on the intended use in the key populations, most in low-middle income countries where these tools are not available. This also serves to set priorities not only for researchers, but also for funders and developers. WHO does play a crucial role here to bring people together, scientists, academic, public health specialists, and particularly people like you, clinicians from affected countries and regions. Okay, next slide. We can just maybe just next slide, please. You can just maybe control it. It's very difficult here. It's stuck. Okay. So developing a target product profile is just the first step to push development of a particular product. Development of several roadmaps on how we get there, which includes not only product development, but other public health intervention is important to make sure all the stakeholders are aligned and so we can follow the progress. Next slide, please. Okay. How about in terms of access? So here is access to data. There are now global norms for sharing data. And these are kind of the policy statement, position statement on what is really good practice on data sharing. First is such as clinical trial registry. So there is a clinical trial registry, and researchers are encouraged to all clinical trials to be registered so we can keep track of the progress and also to avoid redundancies in research. Next is public disclosure of all interventional clinical trials must occur by 12 months from the primary completion date of the trial at the latest. Now, in a public health emergency, this 12 months, it's too long. So the recommendation is that the sharing of data should be disclosed as soon as preliminary results are available. Next is open policy, that we need to access trial results. This should be done and made easily available to scientists and clinicians. So we all are aware of the obstacles to access publications, for example, because we have to pay for the article to access it. So we should all aim to submit to an open source publication. Next is cost of drugs, access. So we know that generic competition is one strategy that works to drive the price of drugs down. For example, we know this in HIV. The availability of generic has allowed the cost of HIV drugs to be lower and more affordable. More recently, also for drugs for resistant TB, although this is a very small drug-resistant TB market, this is a very small market, but the decrease in drug price was also gained through generic competition. For linezolid, for example, we come from a situation where in 2012, we had just one innovator drug and one quality-assured generic source. But in 2018, there are at least 7 quality-assured generic sources of linezolid. Finally, there is more recognition that the current business model to develop health products is not necessarily working. I showed this in my previous example for the dry antibiotic pipeline. There is this concept of the linkage. What is this? So it essentially means that research and development funding should not be tied to the price of the product. So that R&D incentives and funding mechanisms that involve granting or extending a monopoly of a product to charge high prices, this is not the linkage. The key principles of the linkage are elimination of monopolies. Monopolies mean that companies can charge a high price. Having a monopoly over one product should not be the incentive for research and development. Instead, have other incentives to drive research and development. The linkage models combined expanded government funding for drug development with cash reward incentives to researchers and successful drug developers. For example, do we know a lot of the research for products we know are heavily funded by governments? Governments should not pay twice for the drugs, one during research and development and one after once it reaches commercial availability. Several mechanisms on how to implement the linkage are proposed by a growing number of government representatives, international leaders, and NGOs. Anyone in product research and development should try to understand this beyond just the scientific and technical aspects, as eventually, isn't this why most of us are driven to do research? So to be able to link this to product development that's accessible to those who need them the most. So in conclusion, the global community will not get rid of the problem of infectious disease. Good news for us all, we have job security. Many challenges remain, but there is a growing awareness in the global community to work collectively on a roadmap to tackle infectious diseases. More and more people understand that we need a better way of conducting research and development, that they should be driven not by profits, but by real public health needs. As infectious disease clinicians, we are in a unique position to improve the lives of our patients, but also advocate beyond our patients by using our first-hand experience and understanding the wider policy and environment that has a significant impact on the control of infectious diseases locally and globally. Many of you are probably not only clinicians, but leaders, policymakers, and educators. Do not miss the opportunity in those various roles to connect the dots, speak up, and affect change. As a group of infectious disease experts, the Philippine Society of Microbiology and Infectious Disease is a strong and legitimate platform to collectively influence and inform public health policy. I strongly support PSMID and its role and give my best wishes on all its future endeavor. So thank you again for the opportunity to speak today, and have a great conference.
Thank you, Dr. Arlene Chua. May I call Dr. Panaligan and Dr. Isa Alejandria to join Dr. Alora to present the certificate of appreciation to our speaker. So once again, we thank Dr. Chua for her precious time to share her expertise with us this afternoon. May we invite everyone to proceed to the exhibit area in the first floor for the opening of exhibits, and be back in 15 minutes for